Hello, everybody, and welcome. And I'm so pleased to have Professor Tiziano Barbui. I don't know if I pronounce your name right.
Perfect, perfect.
You have to excuse.
Don't worry, don't worry.
Anyway, I'm so pleased. I've heard you twice before during the mini MPN Horizon. And I also had an opportunity last year to hear about your project and research. And it's so really interesting. And I'm so pleased that Monica had a pleasure to have contact with you and that you are able to have a presentation for our Swedish MPN group. And I also know we have people from other countries and Scandinavia here today. So that's very interesting. Thank you very much. And I think I hand over to, do you want to say anything, Monica, about hosting the?
Just to say thank you all for joining us. I have currently muted everyone just to prevent any background noise. I've already passed on some of the questions that you sent me in the registration form. Any additional questions that come up, you can put it in the chat. And if we've got time at the end, we will take those questions. But yeah, take it away. I look forward to hearing your presentation, Tiziano.
Okay, thank you. Thank you very much indeed for this kind invitation. Today, I will discuss with you some experiences we got on MPN during the pandemic. And the most frequently asked questions, Monica wrote to me, try to discuss these points. And I accepted with very well these questions because these are really the questions raised by patients during the pandemic. The first question is whether patients with MPN are at higher risk to get infections generally outside the COVID, before COVID. Among MPN patients, which is the category of patient most vulnerable to get infections? Can drugs that you use to control MPN proliferation can enhance the risk of infection? This is a very important question during the pandemic, around the pandemic. When a patient with MPN has a COVID, which are the problems? The problems are those commonly seen in the general population, plus other specific problems. The first is whether MPN can risk more than the general population in terms of mortality, for instance. The second question is the thrombosis. You know that MPN are prone to have thrombosis. What happens when a patient with MPN, having had prior to COVID an episode of thrombosis, and during the acute phase of infection, do these patients experience more thrombosis than general population? This is a great question for patients with MPN. Vaccines. Now vaccines are very, very important as well. Should people with MPN be vaccinated against COVID-19? of course, everybody should be vaccinated, but we will see there are some patients who are reluctant to be vaccinated. Are there any COVID vaccines that should be avoided for people with MPN? And the last question is, how does MPN treatment affect the efficacy of COVID-19? These are the questions I'll try to solve and to answer during my presentation. So the risk of infection in patients with MPN derives from a registry. This registry is a Swedish registry. My friends, Dr. Halkans, Dr. Magnus Björkum in Stockholm, in Karolinska, they did a very nice study published very recently in the annals, in leukemia, sorry. They did a population-based cohort study. So you have in Sweden a registry. All doctors who see patients with MPN or other diseases, they have to report these patients to a registry, national registry. So they had the opportunity to examine more than 8,000 patients with MPN. At the same time, they registered the infections in a control population, 32,000 controls, meaning these are controls because they have similar age, similar sex, but not with MPN, other diseases. So the hazard ratio is the probability to have the infection in patients, comparing this rate with the rate they observed in the controls, in the normal people. What they found is that the risk of any infection in a patient with a PV, ET, or myelofibrosis is twofold higher than the normal population. This is for bacterial and also viral population, viral infection. This is very important. So the risk is the double that of the normal population. And which is the disease among the MPN with higher risk? The disease is primary myelofibrosis. 3.7, meaning that the risk is fourfold higher than in normal population. So patients are at higher risk to get infections. Another point in this study is that among the drugs used to control the diseases, the MPN diseases, you don't have any enhancement due to hydroxyurea, to interferon, to anagrelide. On the contrary, ruxolitinib, Jakavi, is the drug that is associated with a fourfold higher risk of getting infection. This is an important point to be considered. The drugs, some drugs can affect the risk of getting viral infection. And this is the cumulative incidence over time. So years, 5, 10, 15 years, and this is the control population. As soon as people get older, you see here the risk, the cumulative incidence of infection increases, but the increment is much more pronounced in patients with MPN. Why this? The reason for that is because patients with MPN have an immune system that is not very good, because there is a dysregulation of the system of the immunity in patients with MPN. So that what happens in people once they get COVID is terrible. I am speaking, giving a talk from my hospital. My hospital is in Bergamo. Bergamo is a city had the highest rate of additional deaths during the first wave of infection. You remember, 6 times higher than in 2019. In March 2020, more than 5,000 people have died in Bergamo province. That includes about 1.2 million people, 4,500 of which were due to coronavirus infection. And this is the picture showing military vehicles carrying hundreds of coffins away. And the pages of our local journal were spread over the world, witnessing the tragedy of Bergamo we experienced at that time. It was a terrible time. So during these days, I conceived the possibility to do a study because I thought to patients with MPN, because it's my area of research. I have also another responsibility because I am the responsible of the European Leukemia Net for patients with MPN. So my project, I launched a project in Europe to collect information about patients with MPN by asking center to report in a registry all the story of the patient with COVID-19. And this mortality, thrombohemorrhagic events were collected in a registry that this is an electronic registry based here in my hospital. And the results of the studies were recently published in the 2 hematological journals. One is called Leukemia and the other Blood Cancer Journal. The first question was about mortality. So we were able to collect 175 patients from many countries: Italy, Spain, France, Germany, UK, Poland. I asked also my friends in Sweden. They replied saying that we don't have similar patients during the first wave in February, March. So they said, I cannot help you, but I am ready to help you if, unfortunately, can have similar patients. So, age of these patients were 70, about 70. Age was different, as you see here. In yellow, you see here that the number of patients with myelofibrosis is almost half of all the three categories, meaning that what is saw in the registry in patients I presented to you in the first slides is seen also for COVID disease, more vulnerable disease for getting COVID. So careful for a patient with myelofibrosis. These were admitted to the hospital. Some patients were followed up also at home. They had comorbidities as the normal population. And this is the survival curve. You see here, in the first 30 days after admission to the hospital, 30%, about 30% of this patient died. Overall, the mortality was 28%. But the mortality was particularly elevated in MF, in myelofibrosis. So myelofibrosis, first, is more vulnerable, and myelofibrosis, unfortunately, is the category of patients who can experience a higher mortality rate. Patients before treatment, COVID, and at the moment of COVID diagnosis, they were treated with drugs, hydroxyurea and ruxolitinib in ET, in PV, and in myelofibrosis, but particularly in myelofibrosis, ruxolitinib was used. 56% of these patients were on ruxolitinib at the moment of COVID diagnosis. This is important. Remember, ruxolitinib before COVID is a drug that is associated with most mortality, and getting infection is particularly elevated during these drugs. This comes from the registry, your Swedish registry. That is very, very important. Okay, what we saw is that for those patients who were on ruxolitinib at the moment of diagnosis, you see here, these are patients treated with hydroxyurea. These are patients treated with ruxolitinib. If during the COVID disease, the acute phase of the infection, patient continued to be treated with hydroxyurea or ruxolitinib, you don't have an excess of mortality. But if patients discontinued ruxolitinib during the acute phase of the infection, the totality, almost the totality of patients died. Unfortunately, they were not so numerous, these patients. So this is an alert for the hematologist. Be careful, follow your patients, because sometimes there are some defects of transmission to the ICU, intensive care unit, for instance, and people can discontinue the drug that is vital during the infection. I'll show you why it's vital. Because if you discontinue this drug, you can observe what we called a cytokine storm. Cytokine storm is here well illustrated by this figure, because during the acute phase of infection, there is a release of many inflammatory cytokines that can cause a high inflammatory status in the patient. And the inflammation is deleterious for the patient because it can cause problems, for instance, thrombosis in the heart, kidneys, intestine, lungs, very important, liver, and the blood vessels, and also in the brain. So ruxolitinib has a potent anti-inflammatory action because it inhibits this signaling that is a JAK-STAT signaling. You remember that this is one of the JAK2 inhibitors, ruxolitinib. And this is used because people feel better during ruxolitinib, because in a normal situation, this drug reduces the release of cytokines, release of these proteins that can cause fever, fatigue, and other symptoms that are strictly connected to the disease, to myelofibrosis, sometimes also to polycythemia vera. So it's very helpful, but it should not be discontinued, because if you discontinue, you reduce the potent anti-inflammatory action due to the drug. In this way, you enhance what is the natural propensity of the virus to lead to a COVID cytokine storm. Second question, thrombosis, very important question for a patient with. You know that thrombosis is the major cause of mortality in patients with MPN, one of the major causes of mortality. And once again, we have information from the registry, the Swedish registry, showing the quantitative rate and nonce rate of mortality due to thrombosis here that did not change very much in the last year, especially for some types of thrombosis. So in COVID, outside the category of MPN, you can have more thrombosis in the normal population getting COVID. This is a US registry. Is 3% in hospitalized, but if the patient is critically ill, in need to be transferred to ICU, intensive care unit, the thrombosis is very high, 35%. But in normal wards, patients can experience 3% thrombosis. It is not so much elevated. But what is important, the type of thrombosis is venous thrombosis. Thromboembolism is one of the major probability of this complication. But you can have also myocardial infarction and ischemic strokes. But not only this, and this is specific for COVID. Autopsy series revealed that you can see microthrombi in multiple organ systems, including lungs, heart, kidney, suggesting that thrombosis may contribute to multi-system organ dysfunction in severe disease. And these thrombi are included, platelets inside the thrombi, fibrin microthrombi that are described in venous and also in small arteries and capillaries. And this is a new term that has been coined that is called thrombosis in situ, thrombosis inside the lung, thrombosis inside an organ. So you have the thrombosis that is the normal, the most frequent thrombosis that is experienced by people with MPN, venous and myocardial infarction, but specifically in COVID-19, you have microthrombi in multiple organ systems. And this is the cumulative incidence of thrombosis. This is the mortality. You see the mortality. For those who did not die, they experience thrombosis, reaching 1% in patients followed and managed at home, 3% in non-ICU patients, intensive care unit patients, 18% in ICU patients. So it's particularly elevated in ICU patients. These are the thromboses. These are not the typical thrombosis observed in MPN outside COVID, because most frequent in MPN are thrombosis in arteries. In this case, only few arterial thrombosis we observe, 3 cases. But it's the opposite during COVID. In MPN, we registered more venous thrombosis, particularly pulmonary embolism, associated sometimes with a deep vein thrombosis in the lower extremities, or also splanchnic vein thrombosis. Remember, splanchnic vein thrombosis is one of the thromboses that have been described during vaccination as well. And what is important to know is that people got thrombosis very soon after hospital admission, in 8 days as a median. Sometimes the same day in the hospital, they experience thrombosis. What we observed, this was totally unknown before. This is the thrombosis curve in patients with essential thrombocythemia. So we have 2 diseases: myelofibrosis, excess of mortality; essential thrombocythemia, excess of thrombosis. 17% versus 5% in patients with PV or myelofibrosis. And this influenced the survival of these patients, because those who got thrombosis, they died in a higher proportion than those without thrombosis. So thrombosis is an important complication, can lead to die these patients. And platelets are the key for thrombosis in patients with MPN. Why that? Because you have to imagine platelets as sentinels. They control what is going on the endothelial cells. Endothelium is the cells who cover the vessels, the arterial and the venous thrombosis. As soon as a vessel is damaged, they try to stop the damage by sticking on the endothelium. And the endothelium is attacked by the virus because the endothelium has a lot of receptor for the virus. And the virus attacked the endothelium, and the damage of this endothelium attract platelets. And the platelets can induce blood coagulation and thrombosis, very important cells for the thrombotic complications. So these are the conclusion of for thrombosis. The desire in ET than in the other cells is due to the endothelium, because it involves also the leukocytes in the endothelium. And what we observe also is that this thrombosis rate was associated with a decline of platelet number. They started to have 1 million of platelets. As soon as they experienced thrombosis, there was a decline, significant decline of patients, meaning that these are the components that there is a consumption of platelets during the process of thrombosis. Now, the last part of my talk is the vaccination. Vaccines. You know, we have several types of vaccines. We have types of vaccines, DNA or RNA vaccines. You know Pfizer, you know Moderna. And this vaccine is due to a subunit spike protein. The spike protein is the protein that attacks the receptor on the body, and the virus enter the cells, enter the body through the spike protein. So the tentative for the vaccine is to reproduce the spike protein that is not harmful protein, because is only a subunit, not the entire spike protein, so that this protein cannot induce the disease. It's impossible to induce the disease because it's only a fraction of this protein. And this is a protein that induces the antibodies, you see. Another possibility is that this subunit can be associated with a viral, adenovirus. Adenovirus is not a very disturbing virus for the human being. so that they use as a trial, we say, to induce inside the body the spike protein to elicit the formation of antibodies. There are other possibilities to inactivate the virus or to use live attenuated virus. But usually we have these types of vaccines. We have Pfizer, we have Moderna. Here we have AstraZeneca. We have also Johnson & Johnson vaccine, as you have in your country. One of the considerations you have to take into consideration during the vaccination in a patient with MPN is that MPN, the immune response, generally speaking, in MPN is not so strong because the immune system is altered in MPN. There is a dysregulation of some inactive cells that are constitutively against the attack of virus or bacterial or other foreign hosts. CD4 cells, T cells contributed together with the antibodies to enhance the immunity, but the immunity is not very good in MPN. Moreover, we use some drugs that can induce further reduction of this immunity in MPN. And this is why, because a drug that is again ruxolitinib is okay for the phase, the infection, the acute infection phase of the disease, because it reduces inflammation, is okay. It reduces the inflammation because they reduce the immune surveillance. And this is not good because it can increase the possibility to render more severe the infection, but also to reduce the capacity of a vaccine to do its job. Its job is to produce antibodies and to create a memory for the immunity against the virus. So there are many questions we have in MPN concerning immunity. These questions are well illustrated in a very, very recently Nature Medicine articles just published. The antibody titer, we don't know which could be the good titer of antibodies to protect the patient. What could be the durability of this antibody titer to protect the patient? Do this patient mount also what is very important, a T-cell response for the formation of memory B cells? Are 2 vaccinations sufficient? For instance, because we have to repeat the vaccination for AstraZeneca or for Pfizer, for instance, or are additional doses required? And they can imagine whether the new information can come also about alternative measures for some of these patients. So many questions still. One of these questions is, we have to reach what we call herd immunity. It's very important, herd immunity, because this is another way to protect patients with a low immunity, like patients with MPN. So everybody should be vaccinated. There is no point about that. There is no point about that. In fact, if only few people are vaccinated, these are the vaccinated people, one person is infected, the disease can spread. You see here, this color indicate that few vaccinated people and the presence of a single patient can induce the contagiosity in many of these people. But if lots of people are vaccinated, calculated 85%, 90% ideally of these patients, you can tolerate the presence of two people with the presence of the virus, because these people are protected, can't spread very far, so the whole community stays safe, and this is the herd immunity. So we have to consider this for patients who are reluctant to be vaccinated. And I know that there are many people, the real virus is the media, they said, these people. Vaccine skepticism. So we have to fight these people by telling these people that this sentiment should be deleted in their mind, because we should reach the herd immunity to protect especially those with a low immunity due to the underlying disease. Of course, we have a problem sometimes with the vaccine. And the problem, well-known problems, is the thrombosis that was observed in some specific situation of platelets, because there is a decline of platelets that can precede the blood coagulation system to be activated. In this case, you can get thrombosis everywhere, but especially in two sites, in the thrombosis in the brain, the vein of the brain, and thrombosis in hepatic thrombosis, what we called, and people with MPN know very well this type of thrombosis, that is the splanchnic vein thrombosis, the Bada-Chiari syndrome. But fortunately, if you realize that this rare, very rare complication does occur, you can go to the hospital and the doctors know what to do, injecting intravenous immunoglobulin to stop the autoimmunity. Many times people ask me, but I had a thrombosis in my past story. Have I the risk to get a thrombosis if I'm going to be vaccinated with AstraZeneca, for instance? The question, my answer to this question is the following. The mechanism for thrombosis due to AstraZeneca or either vector viral in vaccination, virus vaccination, is not the same as you had before. This is autoimmunity, is an antibody against you. It's not the same mechanism that involves platelets, that involves other blood coagulation, leukocytes, and so on, that are responsible to the mechanisms of thrombosis during the MPN disease. So my last slide, I'm sorry, but I did a mistake here, is this. I want to make a summary to answer the question Monica asked me to discuss with you. Among patients with MPN, which is the most vulnerable? All are vulnerable, but especially myelofibrosis. Maybe because the immunity is low, maybe because ruxolitinib, that is a drug that is against the immunity of a patient. Can drugs to control enhance the risk? Yes. I did an example. What about the acute phase? Mortality is higher. Mortality, unfortunately, is higher, especially for myelofibrosis. So particularly attention for patients with myelofibrosis. And the risk of thrombosis should be well considered, especially for essential thrombocythemia. About the vaccines, should all people be vaccinated? Of course, yes, yes, yes. 3 years for this question. Are there any COVID vaccine that should be avoided? Ideally, we think that AstraZeneca is a second choice for a patient, especially for some vulnerable patients with MPN. And, but is not a rule. I'm not sure I am right to counsel this. But if possible, we suggest to use the first, that is a Pfizer or Moderna. But I don't have data to support this statement. Should people with MPN be vaccinated? Of course, 3 years. Are there any COVID vaccine should be avoided? I don't know. How does MPN treatment affect the efficacy of COVID vaccine? Maybe ruxolitinib, maybe, but we don't have. Just because we don't have the right answer to all these questions, we reopened the registry. And we are still collecting patients with MPN and COVID from all the centers in Europe, and also one single center in the United States, in New York, from the Cornell University as well. We have now more than 300 patients in our registry, and we want to answer the question. I'm sorry, Monica, not all your questions can be answered properly. Thank you very much for your attention.
Thank you so much for that. That was such an informative and really easy to understand presentation. I think I can say on behalf of everyone that's been listening today, just thank you so much. I think that's exactly what we've been needing. I think information relating to MPN and COVID that's, you know, easy to understand and really targeted. Really interesting what you were saying about the research project is ongoing. I'm really looking forward to seeing the results of that, as I'm sure you are. We have about 5 minutes left. So if there's any questions, feel free to put them in the chat, or you can raise your hand. Questions, you can write them in Swedish in the chat as well. That's not a problem. But there is one question that came in. Someone that had COVID and their platelet levels sank by 50% and then went back up. They were just wondering whether you think they might expect that with the vaccination, the COVID vaccination. Is that something you've heard before?
There are many possibilities for platelets to go down during the COVID disease and also from the vaccination. Not all the decline of patients are malignant decline, say, because we have the autoantibodies that can be induced by the COVID disease, the so-called ITP, idiopathic thrombocytopenic purpura, outside the COVID. So these sometimes are due also to a drug that is very used during COVID, that is heparin. Low molecular weight heparin is very used in patients admitted to the hospital because this drug can protect against the thrombosis, as you know. Heparin is an anticoagulant. So heparin protects against thrombosis, but there are rare cases in whom heparin can induce a decline of platelets, thrombocytopenia. Sometimes this thrombocytopenia due to heparin can be associated also to thrombosis, venous thrombosis, very rare. And the mechanism of thrombosis observed during the vaccination for some vaccines is very similar in the pathogenesis of the decline of the platelets and thrombosis to that seen after heparin. And the same authors, the German authors, recently in New England Journal of Medicine published their experiments on that, showing this. Generally, you can have a decline of platelets after COVID or after vaccine, but not all cases are malignant decline. This should be kept in mind, people. You have to follow, and you have to treat this as with steroids, for instance. Steroids can be important. Sometimes if the decline is a dramatic decline, less than 10,000 platelets, for instance, maybe you need high doses of steroids and also, or in alternative, immunoglobulin, high dose immunoglobulin, as we did in a normal patient with severe thrombocytopenia.
Perfect, thank you. I also had someone ask about PCV. So you spoke about myelofibrosis being increased risk of mortality and ET being increased risk of thrombosis. Do you have any comments on the risks for PCV in particular?
Say again?
Any comments on the risks for people with polycythemia vera?
Oh, yes. Patients with polycythemia is very strange because in polycythemia vera, the risk of thrombosis is not so elevated as in ET. One of the reasons can be that during the COVID disease, you don't need phlebotomies, for instance, because the virus is the phlebotomy, unfortunately, for many people for that. The virus is terrible. What we suggest and the guidelines say is that every patient with MPN in this era of pandemic should well be treated, should be treated according to guidelines, careful. For those who are in need to be phlebotomized, don't wait the hematocrit to go very elevated. You know that we have a rule. The rule is to keep the hematocrit less than 45%. So in this case, you can reduce. Maybe this is the reason, but this is an observation, is a speculation. But it's very interesting, very interesting. Maybe the virus help patients in some way, say.
That's very, very interesting. Very different group, like you say, with the response. I think we have time just for one more question. And I had a question come in about changing vaccines after the first dose.
Yes.
For example, AstraZeneca being given as the first one and then switching to, for example, Pfizer. Do you have any comments or any thoughts about that?
No, I don't have a comment. This is not ideal to me because if you have some problems, you don't know who is the responsible for these problems. So I think it should be done if necessary, but I don't know. I can't answer the question because, as you know, many of your questions have no answers, many, unfortunately. But
yes.
we go on, we go on.
Now I'm looking forward to seeing your research where you try and find a few more answers for us. But I'm aware of the time, so I just want to say again, thank you so much for joining us. I think everyone here will join with me saying thank you, and that it was very, very informative, and thank you very much for the presentation.
Okay.
Can I just have one more question before we stop? Do you see any consideration considering the treatment for MPN patient while getting vaccinated? You have spoken about ruxolitinib, but hydroxyurea or interferon? Yes,
I think you should not change your treatment because if you have treatment to control proliferation, splenomegaly, for instance, in the case of myelofibrosis, you should continue to do that. You should continue. You remember that the period for the appearance of antibodies is about 4 14 days, 20 days. So I think in that period, nothing can happen. So the point is, but we don't know. It's another unmet clinical question. The unmet clinical question is whether the generation of the antibodies is dependent on the drug used by the patient during the vaccination. This is why we are collecting also this information in the registry. It's not easy to get this information because, you know, patients should be asked to participate to a study. It's not easy to convince people to go again to the hospital or in a laboratory to make an exam to see how many antibodies they have. It's not easy. It's not easy. But we try to have. So that continue, don't change anything, because if you are on treatment, it means that your doctor thought that you needed to be treated. It's important, this.
Wonderful. So yeah, thank you again.
Ciao Monica, stai
ciao.
bene? Stai bene? E arrivederci.
Arrivederci.
Au revoir.
Hope you have a wonderful rest of your day.
Bye-bye.
Thank you. Thank you so much.
Bye.
Thank you. Bye-bye.